Well, I think if you're an entirely private physician whose patients pay you, then clearly there's no conflict at all. You only, I think, have, whatever the GMC says, I don't see how you have any responsibility for the population in that setting. But I think if you're working in a universal healthcare system based on general taxation, and based on social solidarity, you have a responsibility to support that social solidarity, and you do that by trying to balance these two things.
Liz?
Well, the way I would look at it is every hour of a doctor's time costs money. So it's this business of value being what you achieve over the resources you spend on it. And in the case of a doctor, it's immediately, it's time. It's also drugs and hospital beds and so forth, but particularly for general practice, it's your time. And so the way I would look at the equation is it's patient health and safety, patient experience, and if you like, almost patient activation, change in the way the population thinks over your time. That extra time commitment of moving from the condition that brought the patient in to health promotion is probably very high value.
Are you saying high value or high cost?
No, I think it's high value,
okay.
Because you get, here they are already in front of you, and now you take that extra step forward, that extra unnecessary bit, if you like, more than what they came in for, and it's probably one of the most efficient ways of making a public health impact on that particular individual.
Okay. Anna?
Yeah, I mean, there are one or two examples in sort of more private systems where they've tried to move towards capitation payment, and in effect, the minute you move away from itemised ways of reimbursement, which, as Iona says, in effect, the more you do to any individual, it doesn't matter whether you're really meeting their needs. And obviously one of the big problems in the US fee-for-service system was that, that the intensity of medicine that was given to any individual was probably actually unhealthy, and that it was too intensive. So there were opportunities to have capitation, but that exactly led to the sorts of concerns that Iona raised about bringing together financial decisions with clinical decisions. And one of the main reasons for the backlash, I think, against managed care, lots of different people have written about this, but I think at least one of the factors there was a decline in public trust, a sense that patients were concerned that the pressures from the managed care organisation, who had a fixed budget, was starting to have an influence on clinical decision making, and that they were making financial decisions rather than clinical decisions. And I think we must learn from that in the way that we construct the incentives, both around GP consortia, but most particularly about how they then transmit those incentives, which they as a consortia will have, to individual practices and individual GPs, because the minute that a patient thinks that the doctor is making a decision not in their best interest because of financial concerns, we will lose that trust.
Yeah, just to add that, I mean, supplier-induced demand means the doctor may be making the decision on financial gain for themselves. I mean, that's the reverse of it, rather than economic constraint. There are financial decisions come in to the other systems as well. Minor point. Yeah, do you want to say anything on that?
Nothing to add to that.
Questions from the audience. There's one here, and then one...
Contributions.
Oh, and contributions. Points. Did I see a hand up over here?
Hello, I'm Marion Lynch from Oxford Deanery, and I run the Leadership Fellow, so I concur with your findings. Because I'm in education and driven by a cognitive reductive process at the moment, I can add in public health to a curricula. I come from public health, so I do. What I can't do is add it into an assessment process. So what in the specialities, particularly in general practice, can we add in so that when the trainees say to me, yes, but is it in the exam, I can say, yes, it is, and you need a moral compass that includes the population, not merely your case-based assessment in front of you.
It certainly is in the curriculum about your responsibility to your entire list, not just the patient in front of you.
completely, it's in the curriculum. It's in the assessment models, though, that we use now within medicine. We assess the individual on the individual care and the consultation and the individual knowledge. We haven't yet captured how we can assess public health competencies, if we have to use it, within the broader medical specialities and other professions.
Liz? Yeah, I think in every curriculum has got stuff in about audit and stuff in about leadership. And I agree with you, a lot of it's lip service in terms of, you know, what real learning is happening and how can it be assessed. What I would do is I would scrap audit as being something that doctors in training have to do. I don't think it's worked out very well, either for the health service or for the doctors in training. I would assess people on the quality of just the sort of topic I was talking about, a cross-boundary quality improvement exercise that would be engaging, exciting. And in order to do that, I think one of the things we have to do is slow down the merry-go-round on which our trainees go round and round, post to post to post, and keep them within a health economy so that they can do something proper that takes a bit of time.
Can I add another thing that I'm not sure is how prevalent it is yet on medical curricula, but given all that we've been saying about the financial situation, clearly rationing decisions already, you know, in a sense occur through discussions that NICE have and decisions that they make around cost effectiveness. And often clinicians do have to engage with that, but many, I think, find it very difficult, and I think a lot of the criticism of NICE actually comes through a resistance to wanting to make decisions based on cost effectiveness. So I just wondered, you know, should we be educating our new generation of medical graduates, or are we, around some of the basics of health economics? Because in future we may not be able to rely so much on NICE, and even where NICE is making decisions, the ability of clinicians to engage in a conversation with a patient to explain why there isn't funding available for a particular treatment, to understand the basic things around opportunity cost. And I have a colleague, an economist, a colleague, who did actually run a module at the medical school in Birmingham. And he had great fun devising it, and I think it went down well. But it was really a totally different mindset for these medical students. And it took a while for them to sort of grasp it, but it was a really, I think, important. But I think it was a trial, I think it was voluntary. So,
Iona, how do you feel about GPs having more of an emphasis on health economics?
I think we all need to understand more health economics, but I think, I personally am dismayed about the declining role of NICE, because I think it brings those decisions much closer to the consulting room again. And I think that you need to make decisions about the cost effectiveness of therapies on a national level, and to have them to be made locally is actually preposterous in terms of the pressure it puts on local clinicians. You've got we can see sort of shroud-waving journalistic policies being reenacted across every locality of the country and making everybody feel miserable and uncomfortable. And I think NICE has done a fantastic job in terms of producing a rationale that it is possible to understand and explain for why some drugs are approved and some drugs aren't. I would actually have liked them to have been a little bit more courageous on a few issues.
Thank you.
Hi, I'm Jenny Shand. I'm Director of Integrated Care at UCL Partners. I'm quite interested in do all clinicians have a responsibility for the population as well as the patient? I think there's a very powerful discourse around the primary care responsibility, and particularly being the natural gatekeepers, many people term them, with a population being their list, and with the incentives that are being put in the system with GP commissioning. I guess my question is, how would you incentivise and encourage clinicians working in a more acute setting to actually have a responsibility for the population when their role is very geared towards episodic care and management of an individual while they're in their institution? How do we get them to think much more about population health? I think also bringing in some of the things that we've seen from evidence, such as smoking cessation. If you catch someone after a very acute exacerbation, you're more likely to prevent them from smoking in the future than if you wait until they then present back at the GP practice.
And can I ask you, did you feel that Muir's, I'm going to ask Muir to answer this, but did you feel that Muir's proposal would answer that on that? I mean, could you see that working?
I think it's probably thinking more holistically about clinicians in an acute setting. So you can have champions of population health, which I think alludes a little to Muir's approach, and of having individuals, within a geography who are responsible for ensuring and, I guess, sort of singing the song on population health. But it's more about every single intervention that an individual has with the system is an opportunity to promote population health, and how do we get the broader role of clinical intervention as is required.
Thank you.
Yeah, language is always a problem. See, public health is a difficult word because it means to some people the health of populations, others an occupational group. And I think you and I are using slightly different terms. Population health of populations. I do think it's very good for the trauma surgeon to turn up with a white coat with blood on it at the licensing committee, for example, to talk about the problems of alcohol and violence. I think they have tremendous impact, and we are looking at ways in which the hepatologist would feel some responsibility for alcohol policy as well. But I was speaking a little bit more now, I think, about population. I was using the word medicine to mean the treatment of people, including the treatment of people that aren't referred to hospital, because you could divide healthcare into two types of service. There's a broken leg service, where if I break my leg out there, I don't need general practitioners, or I'll probably be scooped up and taken in. 100% of the people in need get there. And then there's the pain in the knee, chest pain, breathlessness type of health problem, or rheumatoid arthritis, inflammatory bowel disease type of problem, where only a proportion of people get to the service that's most likely to help them. But it's clear now that we cannot continue by referring everything to a hospital service. And I'm actually starting to run workshops where I'm banning the use of the words acute, community, outpatient, chronic, and sometimes hospital, except as a description of a bit of real estate. So I think we've got to look at new ways. So I was speaking we were thinking, I've got a draft job description which I'd like to see for a 2-session-a-week job for one of the 5 respiratory physicians in Brighton to be paid for by the 3 GP commissioners in the consortium in East Sussex. That's an example. But you're also raising the appropriate thing of the contribution that clinicians working not in general practice can make to improving the health of populations, for example, by prevention.
Liz, as a person not in general practice.
Yeah, well, I mean, rheumatoid arthritis, I'm a rheumatologist. One could make a huge difference to the outcome of rheumatoid arthritis in many patients if better education of the public and indeed of colleagues in all kinds of specialties revealed that how important it is to catch an early inflammatory arthritis before the point at which you have the diagnostic deformities and the diagnostic erosions, at which point you're already well down the track. And I think there's a huge amount of work, for example, to be done in educating the public. And as I understand it, our cancer results are poor, not so much, or not as good as they should be compared to other countries, not so much because of restriction of the drugs as because of delay in diagnosis, because of lack of public awareness or lack of awareness amongst the doctors that first see the patient. So I think there's much that we could do in that kind of disease-related outreach, reaching out, and I think the work on diabetes has shown that, and indeed on blood pressure has shown that you can make a difference by reaching out. I remember when I was first asked this sort of question, what are you here for as a rheumatologist? I thought it was a very stupid question. And I said, I'm here to see patients and make them better. What's this about? Over the years, I realized it's a bit more complicated than that. And this sort of concept of the population is one of the ways in which it's a bit more complicated than that.
Thank you.
Yes, I'm Derek South. I'm an independent researcher for the NHS from a non-medical background. I was particularly interested in the reference to education, but I was looking at from the patient point of view. I presume actually there's a word in the title there which is understood. Do all clinicians have a responsibility for the health of the population as well as the individual patient? I was just thinking whether what the panel would say about what we had this morning about silos. We've got the silo of the health department, but what about the education department? And what about early years learning? And how much could the schools actually do to actually introduce, indeed, what the NH is for, and health nutrition, and really helping perhaps in a community that has particular problems in health? Couldn't that be brought into the education? Be interested in what they say.
Thank you. Anna, you have an education hat on as well, or comments on that?
Not really.
No, there you go. There's a silo we've identified.
Well, I honestly do think that it's extraordinary how much people know about how much and not about their own bodies and how they work. It's actually quite extraordinary. It's not well taught in schools. It's not well understood. I asked my husband the other day whether he knew where the spleen was, and he put it somewhere in his brain. So it is actually quite extraordinary. We don't do enough of that. So the activated patient, nice concept. How about the activated member of the population? And who, if not doctors, is going to spearhead that kind of improvement, that kind of movement? I mean, I think that's what I'd like to see unlocked, is the resource that the innovativeness, the resource that's locked up in people who are only focusing on the doctor, on the patient in front of them, when they could have so much more impact if the angle of the lens widened out.
So could Muir's plan incorporate education of the public? Is that part of the idea?
Yes, I would see, the question I'd ask Liz and her colleagues now is, how many rheumatoid arthritis services should there be in England? A service is a set of objectives with a common set of activities and an annual report. And I'd like someone to be who's responsible for rheumatoid arthritis in Birmingham? Now, you could say, oh, well, you're the chief executive of the West Midlands SHA, but that doesn't make any sense to me. And it might be that there are 2 or 3 rheumatoid arthritis services in Birmingham. It's quite a common disease, and it doesn't require a lot of technology, so it's not like saying it's like epilepsy where you might want to rate it on your audio services. But I would see the person who had the 2 sessions a week. 2 sessions may not be enough, but nothing's enough for everything. I put education of the public and patients as part of that response. It's very light touch, you see. It's just that influence with the local education department or whatever. Liz, how many rheumatoid arthritis services do you think there should be in England if we could map up?
Notice of that question.
Thank you. At the back there.
Thank you. I'm Kamal Bishar. I'm a GP and a BBC lead in West Essex. Can I just go back to Iona's comment about how disastrous it would be if we were to make financial decisions at a local level? I mean, up till now, we clinicians have been living in a pretend world. We make clinical decisions and are not concerned about financial implication. It's someone else's problem. And now it's being brought closer to us, and it's only one step removed from the patient himself. This is the person who should really be involved in making the decision. And unless we bring them in the loop of making these decisions in the consulting room, we're never going to succeed. Do you have any thoughts on that?
I don't think that that's quite accurate, that we have been making our prescribing decisions in a vacuum and not thinking about cost. I've certainly spent 34 years thinking about cost.
Well, I wasn't thinking of you personally.
No, but I think everybody spends that time thinking about cost. And one of the best things that we've had is an awful lot of feedback about our prescribing decisions and the financial implications of those. And nobody could say that we're not fully aware of the financial implications because that service is provided. In complete contrast to any financial information about how much it costs on our investigations and our referrals, which has been very, very hard to get, but we have had the information on our prescribing. So I don't think it's right to say that. But I just think if we are headed for a postcode lottery like we have never seen it before if we're not going to have certain decisions made at the level of the nation. And if we have a national health service, I think that patients should be able... I mean, I didn't agree with everything that the guy from the Veterans Administration said this morning, but he did say about there are certain things that you have to be able to expect wherever you are a patient. And I think the sort of repertoire of drugs is one of those. And I also think that many patients are acutely aware, many very, very sick patients are acutely aware of how much they're costing. And they apologise. It's one of the most painful things that happens when someone is having the most awful time and they're apologising to their GP for how much they must be costing the service. Now, when people are really, really sick, that isn't the sort of burden that we should be putting on them. I think it's perfectly reasonable to discuss the different prices of different regimes of blood pressure treatment, or things in you're treating a relatively well person, and explaining elements of cost benefit and explaining why we should use generic drugs and not proprietary drugs and why we shouldn't see drug reps and all that sort of stuff. But I think to burden the really sick with a feedback about the cost of their treatment to the taxpayer is that goes beyond my ethics.
Well, you see, I mean, if you look at the there's a 15-fold variation in the percentage of people with TIAs who've been treated. The medical profession is making decisions with huge resource implications, both for good and for ill. Primary care, the variation between primary care teams is much greater than the variation between PCTs. So I think this is one of the issues coming out of the Atlas, is that we first of all need to recognise that we're in the business of making decisions within finite resources. I often say to colleagues who say they don't want to make decisions about resources. I say, what time do you go home? They say 6:30. I say, well, you've made a decision about resources already. And one of the lessons that's been learned over the years about program budgeting, which is what we're proposing, is that it's been very well described by Iona, you have to have bits of the discussion where we don't mind talking about money, because everything's to do with money, but that's a separate bit of the decision about the eyeball to eyeball. And I think it is. I think there are big problems about the decentralisation, but we're proposing what we call do once and share. Let's get one consortium to really sort out rheumatoid arthritis, for example. We'll get the British Association of Rheumatologists to go to Oldham or somewhere. I think it is Oldham. We're discussing this actually, musculoskeletal. And then you'd have one group of people who were population orientated, who really understood rheumatoid arthritis, and you'd have rheumatologists who really understood what was going on, and then that decision should be made once nationally. The next day, anti-TNF drug that comes up, we should do that once. We may not pull that off, but the thought of, well, I know 152 PCTs did not address these issues properly. It doesn't look as though there'll be many more consortia, actually, fun enough. They're looking bigger every time you look at them. But I think it is this issue. We are making, as you know, as a profession, resource decisions at the moment. We're just not making them very explicitly or very well.
Thank you very much. Question there, the lady. No more questions. Question anywhere else at all? Or comment? Oh, great.
Hello, Fleur Kitzel from South Central Strategic Health Authority. I'm just interested, going back to the actual statement, and I'm reminded of something we talked about a few years ago in leadership development, which was the NASA model. If you remember, somebody visits NASA and finds a man sweeping the floor and says, what is your job? And he says, I'm helping to put a man on the moon. And that sort of reminds me of that in a sense. Anyone involved in healthcare surely has a responsibility, although the roles are different, for the whole purpose of healthcare, which presumably is to make the health of the population better. So I think it all depends, and then we get into semantics about what do we mean by responsibility, what do we mean by roles, and we can have various different models of what that means. But I suppose one of the questions I would have based on that is we often talk about in this country we have a managed healthcare system. And yet, as soon as we try and manage it, nobody wants to be managed. So we do, to some degree, have a managed healthcare system. That's what people elsewhere think we have. It doesn't always feel that, and it depends again what we feel. What do we mean by managed? Do we mean standardised, or do we mean centralised? You know, what do we mean? I wonder what the panel, any member of the panel would like to comment on that.
Well, thank you very much. That's a very good question to allow us to end on. I'm going to ask each member of the panel to respond to that question and just give a final remark. So, Anna, do you want to start with that?
Yeah, I don't think we do have a managed system. I don't think we have, because different bits of it are pulling in different directions. And that's the problem. If we're really going to sort out population health, then we do need all the bits of the system, in much the way that Muir described, to be pulling in the same direction. And I think that means looking at population data so that we're sure that when the clinician is in the consulting room with the individual patient, they can be confident that they've got the right patient in front of them, so that unmet need is being met, and that people who are getting too much care, don't get too much. So I think there is a need for.
How do you do that?
Sorry. Well, what I mean is, yeah, okay. What I mean is that we're using our high value professionals in the most appropriate way. We've got the right skill mix. I think that is about a population perspective. It's about saying we've got a limited amount of both money and people. We've got to make the best use of resource to maximise health. And I think that can only be done in a system where the parts are pulling in the same direction. And I think that's what we haven't got at the moment. And I think there are some of the policies at the moment mean that continues to pull in different directions. We've got to hope that some of the new arrangements will bring those together.
Thank you. Iona.
One of the very few sensible things that Tony Blair ever said was education, education, education. And if you want to improve the health of the population, you don't go to the health service. You invest in education, which is the point I think that you were making, particularly the very early education for very small people. What I think that the main purpose of the health service is to care for the sick, surprise, surprise, and that is where, I mean, that might have been a more controversial topic, really, because that's where I reveal my true colours in terms of
you were too frightened of that,
of the individual patient. So, and I think that if you are caring for the sick, then that does put limits on managed care, because you are going to tailor that care to that sick person according to their own aspirations, values and priorities, which may not be the same as the sort of normative public health view about what a standardised person should want and expect at this time. Because as Samuel Beckett said, most people most of the time want to live forever, but some people some of the time, and some people all of the time don't. And we don't accommodate that sort of different aspiration into the way we talk about health. It's what I said about standardised interchangeable units of health need, which are patients. They're all completely different. And some of them want lots of treatment, some of them don't want lots of treatment. There is no single right answer for most situations, despite the proliferation of guidelines to which we are subjected.
Thank you. Muir, briefly, if you would.
We're managing the wrong things. I've had 22 reorganisations of the health service, and they've made very little difference. Some made no difference at all. And before my first reorganisation, there was a thing called rheumatoid arthritis, and there was a thing called headache, and there was a thing called bipolar disorder. 22 reorganisations, we know no more about, as a nation, what we're doing, what value we're getting, what the outcomes are, and what the expenditure is to the nearest £100 million. So I've got back involved in this, because when there's more money, no one's interested in these sort of things. But thanks to bankers, there's a chance that we will see this reorganisation, and I'm not speaking about these managerial issues about decisions, but we cannot go on, we're managing the wrong things. When we know to the nearest pound and what we spend every health centre and hospital, and not the nearest 100 million what we spend in pelvic pain or epilepsy, we're obviously managing the wrong things.
Liz.
I went to a wonderful medical school, and I remember way back when being, it's shut now, of course, remember way back then being asked to justify money going into healthcare as opposed to it going into housing, education, and all kinds of other socially important issues. And I think that remains true. I think that I don't think it's a sickness service. I don't think it should be a sickness service. And I do think that doctors have a responsibility to consider the value of what they're doing in the context of an economic crisis where other things like, for example, education, social care, also demand resources. So I think we all have a social responsibility, and I don't think doctors can be exonerated from that.
Thank you all. We must leave it there. I'd like to thank our speakers and the audience for their great contributions.